Hello, everyone, and welcome to today's live broadcast, The Inhibitory Role of Specific Macrophages in RCC. I'm Alexis Krause of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Visiopharm. For more information about our sponsor, please visit their website at visiopharm.com. Now, let's get started. I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. If you have trouble seeing or hearing the presentation, report your problem by clicking on the Ask a Question box located on the far left of your screen. I will now turn the presentation over to Brandon Hopkinson to introduce our speaker for today. Brandon, welcome, sir.
Hello, and thanks for joining us today. My name is Brandon Hopkinson. I'm a product marketing manager here at Visiopharm, and I'll be your moderator for this lecture. Today we have Dr. Elfriede Nößner, head of the Immunoanalytics research group at the Helmholtz Institute and a professor at the Ludwig-Maximilians-University in Munich. She is a board-certified immunologist with special expertise in antigen presentation and T-cell modulation. During today's webinar, she'll discuss the inhibitory role of macrophages in immune oncology with a focus on renal cell carcinoma. Thank you very much for your time today, Dr. Nößner, and I'm excited for the presentation, so I'll let you take it from here. Please begin whenever you're ready.
Thank you very much for this very nice introduction, and I welcome you all to today's webinar. And the title is The Inhibitory Role of Macrophages in Immuno-oncology and the Renal Cell Carcinoma. I will start with the current status of immunotherapy or cancer oncology therapy, and I introduce you to the new area of immuno-oncology. This is with two new therapies, the adoptive T-cell transfer and the checkpoint inhibition. Here is shown the checkpoint inhibition, and what is new about it and what's the new area about is that now we can achieve long-term control of tumors, even in metastatic situation, as you can see in the top. So for patients who have failed all therapies, now there are options to achieve long-term remission and durable responses. And here shown in green is the survival curve of ipilimumab, and in blue, the nivolumab monotherapies, two checkpoint inhibitors. The immunotherapy started a new paradigma in tumor therapy. It's no longer like with current or classical cancer therapies that the tumor cells are the direct target of therapeutic inhibition, like chemotherapy, tyrosine kinase inhibitors, or anti-VEGF therapy. They target the tumor cells directly and kill them. However, tumor cells who do not have the target molecule, they are resistant and the tumors will eventually grow out. Immunotherapy is we mobilize our own defense system to fight the tumor cell. As we do all know, is the immune system is dysfunctional in the tumor microenvironment, and the new therapeutic applications reactivate those existing T cells by releasing the brake with anti-CTLA-4 or anti-PD-1, PD-L1 checkpoint antibodies. The consequence is that the T cells will become reactivated and now can kill and destroy the tumor cells. The second therapy is adoptive T cell transfer of engineered T cells, where the T cells are equipped with new receptors like the chimeric antigen receptors, which we know as the CD19 CAR T cells for the treatment of leukemia and lymphoma. Here, new T cells are given to the patient and they can directly attack and destroy the tumor cells. This new therapy was possible through scientific knowledge by two seminal research scientists, Jim Allison and Tasuku Honyo, Jim Allison discovered the CTLA-4 in 1987, and he recognized that by inhibiting the interaction of CTLA-4 with its ligand can initiate an immune response. Honyo discovered the PD-1 and discovered or recognized that this is a negative regulator of immune response. And the scientific knowledge was translated to clinical application by the development of a number of different monoclonal antibodies, nivolumab, pembrolizumab, atezolizumab, durvalumab, ipilimumab, and so on. There is now a number of therapeutic antibodies which are active and effective in clinical application. So the mode of action is that, like anti-PD-1 or anti-PD-L1, they release the brake in the effector phase, so in the tumor microenvironment, with the consequence that more tumor cells are killed with existing specificity. Anti-CTLA-4 works in the priming, in the initiation phase of the immune response. It takes out the brake in the priming phase, leading that more T cells and T cells with new specificities are being generated. The advantage of the new specificities is that now additional tumor cells can be killed. However, that has also the risk of autoimmunity, because maybe, possibly, also cells are being killed. The current status with this new development is that we can achieve long-term tumor control in a number of tumor entities. We have those tumors that respond very strongly, like Hodgkin's disease or Merkel cell carcinoma. We have most tumors who respond intermediately, like melanoma, lung cancer, bladder cancer, renal cell cancer, and so on. So it has to be noted that we have responses across many tumor types. However, there are some tumors like pancreatic or prostate who do not respond or do not respond very well. In general, we have to say that only a subgroup of patients responds. And the question is, who is a responder? Why are others non-responders? And how can we turn a non-responder into a responder? Currently, experiments are done with combination therapies, here shown anti-CTLA-4 and anti-PD-L1, and you can see the response rates are increased with regards to comparison ipilimumab and nivolumab, here in green and blue, compared to the combination treatment with nivolumab plus ipilimumab in yellow. However, still, we have 40% non-responders. And I highlight here that we have a combination of two T-cell targeting therapies. And what I want to show you in the next slide, that the immune system is much more complex than just having T cells to do the job. We need to know what the immune cells are required, what they do need for rejection. And we have to find out case individually, meaning personalized therapy, where is the problem. For that, we have to look at the tissue environment and see actually what the current status of the immune system is at the tissue site. And how can we do that? For that, we have to look at the tissue. We have to characterize the tissue environment. And we have to find out not only the number, but also the type and the functional orientation of the immune system. We have to find out about the localization of the immune cells. Are they in the tumor core, in the invasive margin, in the stroma, or even are they in the metastatic site or in the primary tumor? And finally, we also have to find out whether the immune cells communicate with each other and how and what they communicate about. How can we do that? How can we define the immune contexture, those of type, density, quality, localization, communication? We can take the tissue, dissociate it, and acquire the TIL, so the tumor-infiltrating immune cells, and do a flow cytometry analysis. By that, we can find out what type of T cell is, what type of immune cell is there. And as an example, for the renal cell cancer, we have about a 1-to-1 ratio of T cells and myeloid cells. So it's not only T cells which are in the tissue present. Then we have a small number of NK cells, meaning natural killer cells, and B cells. With this type of analysis, we can have a deep insight into how and what type of immune cells are there, but what we do not gain is where are they located and do they communicate. For that, we have to look at the tissue. We have to look into the tissue site where actually the communication might take place. And by that, we can see that, as an example, the renal cell carcinoma, we have T cells, here stained in red, and NK cells, again stained in red, but we also have a number of myeloid cells by different markers, and we can also see that they do have different localization. For example, the DC-LAMP positive lymphocytes, leukocytes are focally oriented, when the other ones are dispersed. The different immune cell types, they also do have different functional consequences and importances with regards to survival. Here we're looking at colorectal cancer, CRC, or renal cell cancer tissue. We look at the CD8 T cells, and we can see here that the number of the CD8 T cells in the colorectal cancer has a positive predictive value for survival, while for renal cell cancer, it has a negative predictive value. The curves are always the ones in red. And NK cells, for example, quite differently, have a positive predictive value in renal cell cancer and have no value in colorectal cancer. The DC-LAMP positive TIL, again, in the colorectal cancer, they have a positive predictive value. In the renal cell cancer, they have a negative predictive value. So the different immune cell types, they can have different prognostic value depending on the tissue type. And how can we further use this knowledge for the benefit of the patient? So we in our lab, we looked at a different type of myeloid cell that expresses the marker DC sign. This is a marker for interstitial, so tissue-resident myeloid cells, as we can find them in the tumor tissue. We observed that myeloid cells with the CD209 surface marker, which we call ERK-DC, because they are particularly frequent in renal cell carcinoma, ERK meaning enriched in renal cell carcinoma, and we observed that a high number of myeloid cells with this marker CD209 indicates a poor prognosis. So the curve in red, high ERK-DC number, meaning poor survival probability, while patients with tumors with low ERK-DC numbers have a better survival probability. And with regards to therapeutic consequences, we have to consider what the mode of action is of these myeloid cells. Why are they contributing to a poor survival? Is it because they are directly tumor promoting by secreting factors like VEGF, TGF-beta, IL-10, or inhibitory surface molecules? Or is it because they communicate with other cells, like a T cell? And as an example, they might have surface molecules that are inhibitory to T cells, so preventing the lytic activity of the T cell, destroying the tumor cell. And that has a therapeutic consequence. If we consider PD-1 checkpoint inhibition therapy, so this interaction of PD-1 with PD-L1 is also a negative signal, and by checkpoint antibodies, we take out this negative signal. If we have macrophages providing also a negative signal, this will prevail even in the presence of checkpoint inhibition therapy, meaning we have resistance to checkpoint therapy because the macrophages still are inhibitory. So we have to find out, is there indeed a communication between these two cell types in the tissue? And we looked at renal cell carcinoma tissue by chromogenic double immunohistology, like CD3 in blue and CD209 in brown, so our myeloid cells, and we do see that these two cell types are indeed very adjacent to each other. So we can assume that they communicate, and we would like to know actually what do they communicate, and for that we need to stain a few more markers, and for that we do need to get into a more multiplex immunohistology with using fluorescently labeled antibodies. And this IF, so immunofluorescent immunohistology, provides the opportunity to use more than 2 markers. And like here, we stained CD3 for the T cell in blue, the macrophage in green, and a third marker, FOXO, which is a transcription factor. And this transcription factor is known to provide cell cycle arrest. It is also known to drive the T cells away from effector function, so inhibiting their killing activity. And when you look now at this a multiple stained, immunofluorescently stained tissue section, we find a situation where a T cell is adjacent to the macrophage and another T cell is not adjacent to a macrophage. And if we look at these 2 different T cells for the expression of the transcription factor FOXO, we can see that FOXO is expressed in the T cell that is adjacent to a macrophage, and it's not expressed in the T cell that is not adjacent to a macrophage. And this information provides us with the knowledge that indeed the macrophage may communicate something negatively to the T cell and potentially inhibiting the T cell. So we can assume that the tumor-associated macrophages are indeed inhibitory cells in the tumor microenvironment, and by that they are relevant targets in oncology. There is a number of publications that indicate this concept that the macrophages may limit chemotherapy, it may limit immunotherapy, and that they are by that interesting targets in oncology. If we know that they communicate with T cells, we do also know that a therapy that is directed towards activating the T cells cannot by itself be optimally active. Therefore, targeting strategies to remove, to change, to eliminate macrophages may be beneficially combined with checkpoint inhibition. Again, multiplex phenotyping of the tissue provides the relevant information whether or not we have to do combination therapy and what combination therapy might be the most effective. Here shown again an example of the renal cell cancer where we have on the top a type of renal cell cancer that has high macrophage numbers, like here the cells in red, and in green it's the T cells. So on the bottom we have an example also of a renal cell cancer that seemed to have very little macrophages present. We can assume from this knowledge that the top patient with a tumor that has macrophages, we likely expect resistance to checkpoint monotherapy. The bottom patient with a tumor that has very little macrophages, we expect that it's likely that this patient is responsive to monotherapy of checkpoint inhibition. So it has a consequence what type of immune cells we have present in the tissue type. In addition, it is important to solve and to recognize the spatial resolution. So whether the immune cells are directly adjacent to the tumor, like here intraepithelial, here this lymphocyte is directly in the tumor nest, whereas all the other lymphocytes here are in the tumor stroma, so not really directly in contact to the tumor cell. Also, with tissue phenotyping, we can determine whether we have communication, like in this situation, where the suppressor in red is distanced to the effector in green. So here we would assume communication does not necessarily take place, and we do not have to consider very strongly in therapy the presence of the suppressor cell. Quite differently to this tumor type, where the suppressor in red is directly adjacent to the effector in green, where we do expect that we have to target both cell types to get a beneficial therapeutic outcome. And finally, we do not want to only look at a very tiny slice of the tissue, because the adjacent tissue may be different. So we want to scan the whole section of the tissue to really completely harvest the information that the tissue provides us. And you will recognize immediately, now we really have to get digital. We have to have a good screening system, a computer-assisted digital observation of the tissue to really harvest everything that the tissue tells us for the benefit of the patient. This is my last slide. I thank you for your attention. I hope I could communicate to you the importance to find out the complexity of the immune system in the tissue type. And I hope I could also show you that although we all believe that our eyes are the best evaluation system, we do need in the future to look broader and to help our own personal evaluation by computer-assisted technologies. Thank you for your attention.
Great. Thank you very much for the excellent presentation. Well, using digital image analysis, especially for those complex immuno-oncology questions, can really detail out the players in those systems. We would like to thank both Dr. Nößner for her time, as well as everyone who watched today's presentation. If you have any questions, please feel free to contact us at webinars@visiopharm.com, or check out our other webinars or additional content available in the Knowledge Library on the Visiopharm website. Thanks again, and have a great day.
Thank you, Brandon, and we would like to once again thank our audience for joining us today and for their interesting questions. All questions asked will be addressed by our speaker via the email address that you provided at the time of registration. We would like to thank LabRoots and our sponsor Visiopharm for underwriting today's educational webcast. You can view this webinar on demand. LabRoots will alert you via email when it's available for replay. Be sure to join us for our next webinar sponsored by Visiopharm, Development and Analytical Validation of Prognostic Biomarkers for Metastasis, on February 9th at 9 a.m. Pacific, 12 p.m. Eastern. That's all for now. Until next time, thanks for joining us. Bye-bye.